Welcome back to another episode. I hate doing intros. Today, we have a good friend, Liz, who I used to work with a long time ago. How long ago now? 10 years?
10 years, yeah.
10 years, really 10 years?
Yeah.
10 years ago. Welcome, Liz. Do you want to introduce yourself? Who you are, what you do?
Sure. I'm Liz, or Elizabeth, and I'm here because I work in mental health services. I'm currently a trainee clinical psychologist, due to qualify soon.
So tell me a little bit about exactly what it is that you're doing. You're doing a doctorate, right?
Yeah.
In clinical psychology. So tell us a little bit about what that involves.
Sure. So it's a doctorate in clinical psychology. There's sort of different types of psychologists, I guess. So other psychologists include like counselling psychologists, forensic psychologists, health psychologists. But clinical psychologists, I guess, are trained to work with more kind of severe, enduring mental health difficulties across the lifespan. So we're trained to work with children, adults, older adults. So that's quite unique about clinical psychologists.
Yeah.
And we're trained to assess, formulate, which means try to build up an understanding of why people might be having certain difficulties, delivering individual and group psychological therapy. And also we're trained to conduct research and sort of quality improvement projects, audit sort of work to kind of improve services. Yeah, I think they're the main things in my mind. There's other things that we do, like we think about like the wider systems. Quite often we're well placed to think about what's going on in a team if there's difficulties in a team as well. And the training's funded by the NHS. So it's a 3-year programme where we're paid to have 5 different placements, and we have teaching, and we also have to do research work within that.
It sounds like a lot. Obviously, I've kind of spoke to you bits and pieces over the years while you've been training, and I know you've had loads of different jobs and placements and stuff.
Yeah.
A face says it all. So give us a little an insight of kind of what placements you've had to work in and what experience you've got.
Yeah. So I think that's one thing that's difficult about the course, is because you feel like you're constantly moving on to the next place. Certainly for me, that's been difficult. So most of the placements are 6 months. So my first placement was inpatient mental health wards. So there are acute wards, and above the next level, sort of beyond acute, is PQ, which is psychiatric intensive care wards. So I was across both types of wards. They were for men and women. And that was based at the Maudsley in London. So that placement involved sort of briefer work. People aren't generally on acute wards for very long, but they're very unwell. So a lot of the work, to be honest, is supporting the staff team as well, because they're very fast stretched, as you can imagine, in the NHS at the moment. So sort of offering spaces for reflection as well with the team. So I was there for 6 months. Then I moved on to a secondary care psychological therapies team, which is, so there are community mental health teams in every area of the UK, and they usually have a psychology team attached to them. So I was in one of those teams, and I'd been in a secondary care psychological therapies team before I got onto training. So it felt somewhat similar. And you get to work with people for a bit longer. Most sort of secondary care teams offer about 24 sessions at the moment. And you see sort of different presentations, sort of different difficulties. And some people are under community mental health teams for, years, because their difficulties are quite severe, sort of long term. And then I was in a children's autism assessment team.
What was that like?
Very different.
Yeah.
Long waiting lists. Yeah, I think the waiting list in Kent then was like 5 years.
Yeah.
So again, you sort of see people, young people, sometimes with their parents, you're assessing them for autism, and it's quite an unusual situation for them to be put in. They're with strangers. So trying to do a bit of work just to ease them on the day, try and relieve some of that anxiety, but also acknowledging that this is like a very strange situation.
Yeah.
Sometimes young people would want their parents with them.
What was the age range that you kind of worked with?
So we worked from, children under 7 are usually assessed within paediatric health. Okay. So 7 to 18. Obviously sometimes people referred when they're like 12 and then we don't see them until they're sort of coming to the end of school, which understandably is quite frustrating.
Yeah.
When parents and maybe the young person feel that they need the diagnosis to help them at school, largely to get additional support at school. And I did manage to do some therapeutic work with some people that had received a diagnosis to help them to sort of explore how they were feeling about that.
Mm-hmm.
And that's how services are set up, but largely that just doesn't happen at the moment because the focus is on getting through these waiting lists. So, difficult situation that services are in at the moment, really.
Yeah.
And then I had a learning disability placement, a community learning disability placement in a mental health service. I hadn't really worked with people with learning disabilities before training all that much. I really enjoyed that placement. Like, you could be quite creative and flexible with how you worked with people. So they were all adults, and a lot of the people that I worked with sort of lived in residential placement or supported accommodation. So sometimes, again, it was working with like the systems around them. And a lot of grief work with people with learning disabilities, because I think maybe there's an assumption that somebody that has a learning disability doesn't fully understand if somebody's died or sort of loss, when actually quite often they do, and it's quite difficult for them if they feel completely overlooked or that they don't understand. So I really enjoyed that work, that placement. I did a lot of like narrative work and tree of life work, which I really enjoy, and like drawing trees and thinking about. So tree of life quite often has like the trunk of the tree, which is like the main supports, and think about the roots where people have come from, and then sort of hopes for the future. So I could think of a couple of clients that worked really nicely with. And then for my final year, we get to choose like a specialist placement.
Yeah.
So I chose to go to the Tavistock in London. And I was in an adult complex needs team.
Yeah.
And they work very psychoanalytically, psychodynamic, which sound like big words, but basically that type of approach of work is thinking about how somebody's past maybe affects the present, but in ways that they're not consciously aware of. And it's trying to bring people's awareness to things that maybe they're not aware of in that way. And at the Tavistock, they offer really intensive therapy. So they see some people 3 times a week. I wasn't offering that. I was seeing my clients once a week, but they see people for long periods of time, and it's quite an in-depth piece of work that they do.
So tell us a little bit about like Tavistock as a general for like people who
So I think most people have probably heard of the Tavistock in relation to their gender identity clinic. So they did have a gender identity clinic for younger people and children that was closed down. They still have a gender identity clinic for adults. And they have lots of other services. So they have CAMS there, they have adult services, different adult services. The whole building is made up of lots of different teams, more teams than I'm aware of. So I think a lot of people think the Tavistock is like specialist, and it is specialist for some things, but it also covers the local area of sort of Camden and other boroughs in London, in North London. So it's not necessarily that people have been specifically referred to the Tavistock. They could just live in the adjacent area, and so they're accessing services like the community mental health team like you would in any other area. But yeah, the Tavistock has quite a unique history, and its history is rooted in psychodynamic theory because of Freud and other sort of psychoanalysts from years ago. So they have a Freud statue outside the building. And it feels like quite a unique place in the NHS, really, to work. Yeah.
What's been like your favourite kind of placement?
Probably the Tavistock. As I say, I also really enjoyed my learning disability placement. I think that placement pushed me outside of my comfort zone in ways that I didn't really anticipate. And lots of like joining up with different professionals. Lots of professionals meetings and things like that. But really, like, I think as a clinical psychologist, like making sure the person that we're actually caring for, their voice isn't lost within that, because that quite often does happen. So I did enjoy it.
I can imagine it's like just constant learning all the time. And like seeing someone completely different all the time as well. Which must be fascinating but also exhausting at the same time.
Lots of learning. Lots of feeling that you're being assessed continually, which you are being. But also lots of opportunities to grow, I think, as well.
What made you want to go into this line of work in the first place? Because ever since I've known you, you've kind of gone, this is what I want to do. And going into your doctorate and stuff. And like, I'm so pleased for you that you're doing that and you're coming towards the end of that now. So what is it that's kind of made you go like, this is me, this is what I want to do?
I think I certainly remember after finishing it. So I did an undergraduate in psychology, and I remember when it coming to the end, and probably during my undergraduate degree, like being like clinical psychology is the thing. I remember, well, even my psychology teacher at school and lecturers at university being like, don't do that. Like, it's so competitive. You need to be good at maths was always the thing I heard. I'm not the best at maths, though. But I never fully understood like why people were saying that. I think if anything, maybe that spurred me on a little bit to be like, why can't I do it? I think we're all like drawn to work in the mental health profession for our own personal reasons anyway, whether we're aware of them or not. But I think for me, like clinical psychology, I feel like there's a good balance between working with different types of individuals. I didn't want to kind of narrow down to just working with young people, although I do really love working with young people. And when we met and we were working with young people. But I also wanted to have the opportunity to move if, that my interests might change over time. And I feel like within clinical psychology, we can also kind of advocate and think about more like societal influences on people rather than, I think quite often what can happen unintentionally sometimes it's like the difficulty is located in the person. And you see that sort of within families, like this person has, I don't know, anxiety, you need to help them. And actually as a clinical psychologist, we can think about lots of reasons why somebody might feel anxious societally. Like with young people, there's so many pressures on young people, social media, limited opportunities for work, to get a house, and all of these things we think about in a way that hopefully doesn't lead to a person feeling like pathologise or like something's just wrong with them, because that's not helpful for anybody. So that's definitely something that has drawn me to the field. I've always been interested in research as well. I've never wanted it to be primarily like the focus of my work, but I think it's important to be building upon the research base that we have in order to make services better for people, to make sort of the support that they're accessing, to ensure that it's actually the best that we can provide.
It keeps it current as well, actually.
Yeah. There's constantly like, sometimes people say that to me, like, how do you keep up with what's going on? Because clinical psychology is broad and you can't, but you can also try to, read and... Yeah.
What's been the hardest part of the training so far?
I think for me, as I said, the constant moving on between placements is hard for me. I quite like to feel like settled and stable in a team and know where I can go for support and who to ask if I'm worried about something. And that's been hard because I've sort of felt that I'm just getting to know a team and then I have to move on. So there's a lot of goodbyes and that's been difficult. I think also the teaching at university has personally brought up a lot in me. We think a lot about like what's going on in the world at the moment and conflicts, and just you're constantly bringing your awareness to parts of yourself that you might not want to look at, and that's difficult, but necessary in order to make sure that you're not unintentionally projecting things onto your clients or missing things that are actually really important to them. So yeah, that's been something that I've had to get used to, and I think that I'll constantly be growing and working on those things. It doesn't just stop as training stops,
Constant works in progress. Yeah. Do you feel like there's any myths around clinical psychology that need to be addressed or that are completely wrong?
Maybe the one about maths. There is some statistics, certainly at undergrad and later on down the line, but you don't need to be a mathematician to be a clinical psychologist, thankfully. Well, I think the fact that we do have doctor titles at the end of training, but we're not medical doctors, I feel like that's something I have to explain quite a lot. And something that I've wrestled with quite a lot, like, I think for a long time I've been like, I don't want a doctor title. It feels like it sets up a really high expectation of what I can provide when actually I'm a human being and I'm usually meeting with another human being and we sort of figure things out together or with families. But I think, maybe sometimes it can be helpful, particularly like when working in physical health settings where there are a lot of medical doctors. It kind of gives you a bit more weight to maybe what you have to offer. And I guess we have done a lot of training, so...
You've earned it. Sure. Yeah. Something that I'm trying to come to terms with. Something to take to therapy.
Yeah.
Fair enough. How different is it? Like, how do you think it's kind of a similar question, really? But how different is clinical psychology portrayed, like, to what it is from what it may be in like films or TV, because people have got an understanding of what that might look like, and they're always showing there's always like psychologists on TV and films and that sort of stuff. So how different is that, or is it very similar? It's quite a big question.
Yeah. I wonder what preconceptions you have now of clinical psychology. I guess in films, like generally, like psychiatrists and psychologists are shown in like white coats and like with a clipboard, and I think quite often people don't know the difference between a psychiatrist and a psychologist as well. So psychiatrists usually, there is overlap though. So psychiatrists usually provide medication, diagnosis, but psychiatrists can also be trained in psychotherapy. I see that quite often. Whereas we generally don't diagnose. We can maybe, put forward our ideas about diagnosis, but generally we kind of steer away from diagnosis because whilst it can be helpful, it can also be really harmful for people and it can stick with them. So I don't know if that really answers the question, but
I guess what are the differences between like how you would work compared to how I would work, perhaps? Because they're very similar in essence, I imagine. I mean, I've not done your training, but what I imagine it to be is very similar. What you described is very similar. But there also feels like there's a lot of difference.
Yeah.
And obviously you've had to have a lot of therapy throughout your training and stuff. So you've got that experience of being a client on that side of stuff as well. So for my own curiosity and, for people listening, like what are those? Why would someone go to a clinical psychologist rather than someone going to a counsellor?
Yeah. It's a good question. Well, I guess we're trained, it's a real breadth. So we have to be trained in CBT and one other therapeutic approach. So that might be psychodynamic, systemic, which is more like family therapy. And then there are lots of other different sort of branches of therapy. So things like cognitive analytical therapy and EMDR, and there's so many. And I think in a way with clinical psychology, you can kind of go down the route that you feel most aligns with you. So two clinical psychologists could look completely different. And some people in my training, know that they wanted to go into neuropsychology, which is again quite different, or they wanted to work with a very sort of niche population. But I think for me anyway, I quite like psychotherapy. So psychodynamic work, I'd imagine, probably aligns quite similarly to what you offer. Whereas CBT is more structured. It's more offering strategies. There is formulation, but for me, like, I find CBT more difficult in terms of delivering it. It can be helpful for some clients, but I don't like to see somebody and think, oh, I need to do CBT, because it just depends on, I think, a person's personality, what they are sort of after. And sometimes, people present and they say that they're really struggling with X, but you end up working on Y, So in that way, I feel like more sort of psychotherapeutic approaches more, you can be a bit more flexible, I guess, in a way. You can be led by the client rather than saying, I'm the expert and because you've got anxiety, we're going to do this strategy.
So it sounds like there's a lot more kind of tools at your disposal, having to train in lots of different ways. And
we can work integratively, which means that I can sit down with somebody and we might be working predominantly psychodynamically, but then I might think, so maybe something comes to mind from another approach and I can use that. So in a way, we do really sort of tailor the therapy to what people are coming along with.
Yeah. I think also the thing that kind of sticks out in my mind, especially with my training, was like, I guess, certain thresholds of people. So when I was training, we got told, I guess as a student, but equally when qualified, obviously knowing where our limits are, not being able to work with someone who has psychosis, for example. Like that is always like quite a big no-no.
Yeah.
In the way that we work, I guess. But in my mind, that's something that obviously you would deal with more, and have that training in and that knowledge to work with someone who is or has more clinical diagnosis.
Yeah. Yeah, I think that is true, yeah. So we do work with people that have psychosis, for example. But I think also a lot of clinical psychologists kind of, because I guess traditionally people with psychosis would be labelled with schizophrenia.
Yeah.
And so a lot of our training is about thinking about, is that label helpful?
Yeah.
Is a label psychosis even helpful? When, yeah, it's sort of, it depends on the individual and how they make sense of their difficulties, I suppose.
Yeah.
They might feel that they're just having a sensory experience, and so we might go along and explore it in that way. Because we all have experiences like that, right? Where we like think we've heard our name called or something. Like we all to some extent have that.
Yeah.
So why do we pathologise it in some people and not others? I think people with schizophrenia really historically have got a bad deal in terms of how the media reports people with schizophrenia. They're always sort of described as being scary or dangerous. And so for our training, we do think a lot about like the societal discourses around that as well. Again, two people with psychosis could have completely different experiences.
For sure.
I guess also, like, diagnosis can be helpful. I'm not saying that it's always unhelpful. You know, if we get a referral through and it says somebody has anxiety and depression, that does tell us something about somebody.
Yeah.
But it doesn't capture, you know, what it's like for them.
Yeah.
And that's sort of where we need to hear more from the person.
Yeah. So on that, that's actually one of my next kind of questions, is that do you think, or what do you think people get wrong about those kind of diagnoses of like anxiety and depression? Because that is something that I know gets thrown around a lot. You know, seeing clients who are saying I'm depressed or I'm anxious or I have anxiety without any kind of diagnosis and all that kind of stuff. Is there anything that in your experience that people get really wrong with that? And I know also, slight tangent as well, like ADHD is becoming very like a hot topic, and I've seen a lot of clients who are saying that they're waiting to get tested or feel like they have this. What's that like in your experience?
Yeah. Well, I guess ultimately, what does anxiety and depression even mean? Like, what does that look like? Because we all feel anxious at times.
Yeah.
And we all feel low at times. So, you know, if somebody comes to me and says, I want my anxiety to disappear, it's not realistic. We all experience anxiety.
Yep.
I guess it's to the extent that it affects somebody. If they feel that they can't leave the house, for example, it's impacting their, you know, their daily life, their ability to function, then it becomes problematic. But then you need to do a lot of like detective work to figure out why that is. There could be a whole host of reasons as to why that is. And yeah, I've worked with people where they find it really like validating and helpful to be told, you know, you've got anxiety, or I guess traditionally it's anxiety disorder, social, you know, whatever it is.
Generalised.
And we do see a lot of that. You get that a lot from GPs in the NHS. This person has GAD, they need help. It's like, but what exactly do they want help for? But equally, I've worked with some people where it's not so helpful. I think maybe with depression, anxiety, those diagnoses maybe don't stick with people in the same way that a diagnosis of schizophrenia or a personality disorder would. Because I think the way that people think about sort of schizophrenia and personality disorder are maybe a bit different. And I think they're seen as kind of common difficulties, anxiety and depression. So again, it does depend on how the person views how professionals are speaking about what they're experiencing. And yeah, as clinical psychologists, we steer away from diagnosis anyway, but we might still work with it in some way in terms of the system, talk about it like that. And so we can challenge sometimes, but sometimes also we'll just acknowledge that that's maybe what somebody wants to call it. And again, I guess some of that does transfer onto ADHD and autism as well, because I guess we think about whether those diagnoses are always helpful, culturally, societally, who are they sort of serving? Is the word disorder helpful? Because that sort of implies that something's disordered about the person, not a difference, a disorder. I personally think that the way that we think about neurodivergence will change in years to come. And we'll think more about how people just think differently, and that not being as disordered, it's just a difference, I'd hope. And that environments need to adapt to people. For example, like in schools need to kind of adapt as to how they meet a child's needs. Don't know how realistic that is.
I was going to say, how likely that's going to be.
But I think some schools are quite good at that.
Yeah, I think there's definitely schools out there that are very open and willing to think in that way. I think schools are a lot of, well, not necessarily schools is quite a blanket statement, but the schools are a big problem in that way of thinking. I think I see a lot of young people who struggle with anxiety, not necessarily depression, but I see a lot of kids with ADHD and stuff as well. And I think the pattern that I've seen working with those kinds of kids are, they don't necessarily they have no understanding of A, what that is, this label, or B, how it really affects them, or how it impacts them in that way, I guess. I've had lots of conversations with kids who've said, oh yeah, I've got ADHD, and I've gone, what does that mean? What does it stand for? And they've gone, I have no idea. Like, it's that classic, or I'm a bit naughty, or I'm energetic, or hyper. But actually, when you break all that stuff down with them, they go, oh, that makes so much sense of why I'm like that. I think there is I'm all for, like you said, that everyone accepting neurodivergence and all that sort of stuff, and it just becoming the way people think differently. But I think while we're throwing out labels, I think we need to explain them a lot better, especially to young people. Sure. It's a minefield, I think, out there.
Because in the same way that you tell somebody they're autistic, what does that mean? Again, to autistic people, there's a saying, if you've met one autistic person, you've met one autistic person. And the same with people that I guess would be classed as neurotypical. There's going to be differences between people that are neurotypical. What does that mean? And sometimes you can see it where, again, the problem's located in one sort of member in a family. And sometimes the want for a diagnosis comes from the people around, because they can sort of pinpoint, oh, everything happened because you had, I don't know, ADHD. We knew there was something wrong with you. And sometimes it can take away from maybe other things that have been going on. Trauma, for example. It's complicated though. And sometimes diagnosis diagnosis is helpful, and it's helpful for people to find like their tribe through people that are similar to them. And it's not until they receive that diagnosis, you know, something clicks and they're like, oh, it makes sense now.
Yeah.
I can find people that are similar to me. But I think we do have to be careful.
Yeah, I think as you're saying that, I was just kind of thinking back to where we used to work, and that I guess there was I don't know about you, but I felt that there was a big sense of community, I guess, in the kids we used to work with at the college. I can think of a few people in particular that we worked with, and that was very much their identity as a unit more than an individual, like and how almost inseparable they used to be to find someone, oh, that they're like me. I get that. And then to, you know,
and I guess that's kind of, as clinical psychologists, we'd encourage that with anybody with any diagnosis. You're not your diagnosis. Let's kind of externalize yourself from it. Because I don't think with any diagnosis it's helpful to be like, this is the entirety of me, because it's not. But maybe sometimes it's more comfortable for it to be.
A slightly different question for you, Liz. How differently, if differently, do men show up in the therapy room to women? Because I feel like I've got an answer for that question, but I wanted to see what your experience is like.
I think quite often men come to therapy maybe later on in life, or when things have got quite, well, really difficult for them. Maybe slightly differently to women. It's interesting because I think that men's mental health is an area that wasn't talked about that much in training, and I wish it had been.
So that's quite. I know you've told me that before, but it still sounds surprising. So,
and there weren't many men in our cohort as well.
How many were in your cohort, like altogether?
58.
58.
And about 6 men, six or 7 men.
Insane numbers. What do you feel like you wished was kind of taught in that area?
Well, I remember us having a session about women's health, and I remember it being like a really good session, really helpful, thinking about like the history of women, where women are at now, sort of at a very unique place where they're juggling work and looking after children and juggling all these roles. But yeah, I feel like, and acknowledging like we live in a patriarchal society, but also like that does harm men as well. And I don't feel like that was acknowledged. Yeah, that doesn't sit comfortably with me, really.
Why?
Well, maybe we're thinking about certain men, I don't know, in that. You know, just the whole sort of discourse that even from when men are very young, like boys, of just like getting on with things, man up, you know, get on with it, don't show how you feel, you know, that kind of will trickle through the entirety of somebody's life. Yeah, I just feel like we need to be talking about it more, really. And I commonly hear that in therapy when working with men.
I was just about to ask you that. What's your experience working with men like?
Yeah. I worked with somebody recently, and he's sort of in his 80s. And he said, I've never, ever spoken to somebody about how I feel. And just the relief of actually speaking to me about how he was feeling And things have got to a crisis point for him.
Yeah.
So I've never done that before. I've never spoken to my partner, my children, nobody. I just think what a burden to have carried your whole life. Yeah, so I think it's huge.
Is there any, I don't know, the people that you work with, but is there any sort of patterns in generations? So you said like that bloke was 80.
Yeah.
And has never spoke to anyone in his life. Have you ever found that gets better as kids, or as men get younger? Does that make sense?
Well, I've certainly worked with like young people, children, where like their parents have sort of brought them to therapy and feel like it would be helpful. Yeah. So I guess that's quite different probably. I don't think that would have happened years ago.
Yeah.
Probably also wasn't the resources, and, you know, the focus was just on other things. You know, children back then were living through the war and things like that. So it's a very different experience. So, yeah, it can look differently in young people where there is the systems around a young person are more willing, I think, to listen maybe. But I do think sometimes in boys it does get portrayed as you need to stop them doing this, being naughty, or they need to go to their lesson, or and sometimes there's additional needs there that get overlooked. I'm sort of actually thinking about like my own brother, and he like didn't like school, and then it wasn't until he got to university and he was told he's dyslexic, and he struggled to read and write whilst at school, and that just was like completely overlooked. And yeah, now he's doing very well for himself. But just like quite a fundamental need really just gets completely overlooked and labelled as something else. I think that still happens.
Yeah, I definitely see that in a lot of the work I do.
And quite often, like, I don't know, this might be a generalisation, but quite often, like, it's mum that comes with, like, young boys that I've worked with, and so quite often I'm curious as to, like, where's dad in all of this? And
yeah, it's interesting you say that, actually. I think sort of more recently I've had experience where dad's brought the son. I've had instances where mum's initiated the appointment, but dad's come along, which I find is really interesting, and really kind of I don't know what the word is, heartwarming, I guess, in a way that actually having a dad like that in this room, knowing how important a male role model is into a young person's life. Yeah, it's really quite nice. So I'm seeing a slight shift in that. Hopefully that continues. Yeah, I think it's probably something that we could talk about for a long time. I've got a different question for you. I think this is something we've kind of talked about a little bit, probably not intentionally. But I think we might have a few different views on this. I don't know. How much of yourself do you think you should bring into a therapy room?
I think we're trained to not to not bring ourselves, but to always be thinking what is the purpose of everything that I'm doing? If it doesn't serve the client, then I shouldn't do it, I guess, ultimately. So I certainly am very reserved about self-disclosure or just revealing, And obviously we think about this in training quite a lot. There are things that are seen that my clients will either see as me being similar or different to them, but there are probably a lot of things that are unseen. and they never really get touched upon.
Mm.
They might show up in different ways. It's hard to know what people pick up on. But yeah, ultimately, I try to keep the two separate.
Mm. Have you ever had like sessions where someone's asked you directly about yourself?
Not really. Not really in sessions. When I've worked in different places, like on wards and things, been asked like generic questions like, are you married, or do you have children, and things like that.
How do you respond to those?
Back then I responded I just told them the answer.
Yeah.
But in training, I guess particularly from like a psychodynamic point of view, we think about, you sort of direct to the client, I wonder why you're asking me that. And that's not to say that you wouldn't answer it necessarily, but like to be curious about what they're curious about in you.
Yeah.
Because it might be communicating something. So yeah, I think probably if somebody asked me that in a therapy session now, are you married? I'd probably say, I'm really curious as to why you're wondering, why you're asking about that, why you're thinking about that. Is this something about like their relationship to marriage, or for example?
Yeah.
But yeah, I'd still feel quite uncomfortable to answer it directly. Yeah.
I think that's interesting. I think because obviously I'm doing this, and I spoke probably not a lot about myself, actually. I've spoken bits and pieces about myself. I still feel like I'm very reserved about what I say, and I'm quite careful what I say, I think. But I think it's very similar to you. I think obviously there's a reason why they're asking, and I'll always ask that question back. But I feel that for me, I guess it's just the way I work, that I think that human curiosity is okay. And obviously we've got very, very different training. And I remember my training was like, obviously we reflect that question back, and don't disclose too much.
I'm all for people being curious.
Yeah,
I'm curious about my therapist. We all are curious.
Yeah, I think for me, I'm quite open to being open, I think. Because I think for me, and what I found is it just quickens the that bond, or that rapport you have with that person. Yes, I'll always probably ask that reflection back. Oh, like, why? Curious why you asked me that, or whatever. But I don't know. I think I don't really know. We've got very similar thoughts about it, but for me, I don't mind. I don't mind it. I don't mind people asking me. I've talked about being a parent and all of that sort of stuff in this room. There's nothing really personal in this room, apart from one thing that no one's asked me about before in this room. So there's not a lot of me on show. But I wouldn't necessarily invite those questions.
Yeah.
Cool, what did you say?
I was going to say, but it is like within your home as well. So I guess that's different too.
Yeah. I guess so. I guess I'm very clear with those boundaries.
Yeah.
Like, this is the room that I work in, but no client has ever been past that door, bar one, maybe two, to need the toilet, who was desperate, and I knew quite well anyway. But other than that, no one knows really the real me, unless they listen to this, and they might know stuff. But I'm quite happy for that, because I think it invites more openness, and I think especially with men who struggle to talk and to struggle to open up. Obviously, I've done quite a lot of charity work with like Making Miracles and baby loss. And I know I have self-disclosed in those sessions, going, I know what that's like. I've been through that myself. And to see those moments where those men's, like their shoulders drop and that relief comes and they go, oh my God, actually someone understands, rather than thinking, oh, this is a professional.
Yeah.
I just think it just breaks that barrier so quickly for me. I'm happy
but
to
I
do
guess the opposite could also happen, where maybe you haven't had a shared experience, and if you were to say, I don't know, maybe sometimes, you know, I haven't experienced that, it might create a distance sometimes. But yeah, I think I just try to be more separate, because it can easily become in our roles that you just take things home.
Yeah. How good are you at leaving stuff at the door, leaving stuff at work?
Usually quite good. More recently, though, in my more recent job, it's more difficult, I think, because people are presenting in crisis, and it's very severe sort of difficulties that people are having. So it's harder, just in terms of like, oh gosh, have I done all the paperwork and, you know, things like that. And but yeah, maybe my partner would have a different view. He's just like, just, you know, take a breath at the end of the day.
Yeah. How supportive is he?
He's very supportive. We do very different jobs though. So he's a computer programmer. So he does a very analytical job still, but he doesn't, he's like, I couldn't do what you do.
Do you find it hard to talk to him about like your day and what you've dealt with?
Not really. I mean, I don't tell him like lots of detail, but I think sometimes he probably doesn't want to hear, you know.
Yeah.
Because it is a heavy job. So, but yeah, he is supportive, and he will remind me he's very grounded, and he'll sort of say it's a job. You know, you need to remember this is a job.
Yeah.
He's very practical. You know, if you're not happy in a job, leave. Just like things like that, which are really helpful reminders, because I can, not see things quite so direct. So that can be helpful. And it's helpful just to have somebody who I'm really close to who just does a completely different job, and just to recognise, you know, people do completely different jobs. Because over the years, like increasingly my friends are people that I work with, so they work in mental health services as well. And I think it's really helpful just to have friends that don't.
Yeah. It's nice to just to mix it up and talk about other stuff.
Yeah.
I feel like I've said it before, I think on the podcast, I think it's doing jobs like we do is often, I feel, you're almost protective of other people's innocence, of like what actually goes on. There are some things that, you know, I would go home and talk to my wife about that I've obviously not, like you said, not details or anything like that, but I've had a hard day, I've dealt with this, for example. But also knowing, you know, all the jobs that you've done, like you've seen a lot. I know I've seen a lot. It's almost like I don't want you to see what goes on in the world, because it can be a harsh, horrible place.
Sometimes I want that for myself as well.
I would love that. I sometimes wish I hadn't seen half the stuff I've seen or know about. Life seems simpler that way sometimes. But equally, it's like, again, I feel that you're able to connect with people on a deeper level because you know those struggles. I don't know about you.
Yeah, I do think that although I don't tend to like disclose a lot about myself, I feel like I'm authentic in my work.
Yeah.
And I go about things with integrity, and I try and, like, wherever possible, involve a person that's in front of me, you know, whether I'm raising, I don't know, safeguarding or whatever it is. You know, it is a very personal relationship. it's different to like how I'd be with my friends or family or partner, but it's a close relationship still. But I just see it, I see it as different to relationships I have with other people in my life, I guess.
How different of a person do you feel you are as a professional to not a professional?
My gut would say like not that different. But I've definitely noticed like changes over time. And it's not until like I am sort of around people that I knew before I ever worked in the NHS, and they're like, what are you saying? Like, just the way I speak and the words I say, and I don't even realise it. And I try to steer away from that because I guess there is a lot of jargon in psychology land, which I think just, creates distance really. So I do think I bring myself, but again, it probably depends what part of me. There's lots of different parts of me as well.
Yeah.
You know, I'm obviously not the same person when I'm like, I know, out with my friends, going to a festival or something, because I am sat with a client, and I think my client, you know, anybody I work with would understand that too. I think they probably know that there's other parts to me. They just maybe don't know exactly what they are, but that's okay.
You're quite good at keeping them in balance, those different parts, do you?
I think so, as much as I can be, yeah. I do feel like, you know, I've focused on my career, really, so, like, definitely through training, maybe that's that work-life balance has been a bit more skewed towards work. And it's only now that training's sort of come to an end, that I can pause and be like, actually, how do I want things to look? Because I do want things to be more in balance. But it's not an easy job that we do. So,
do you think modern life is making us more unwell?
Yeah, I think so, probably overall. And I think through training, like, I've thought a lot about how I care for myself, and thought a lot about the things that make me sort of rebalance myself. And a lot of those things are very simple things, like taking my dog for a walk and reading a book, actually being able to sit down and focus on a book, just actually spending quality time with people where I'm not distracted left, right and centre, things like that. And I think society at the moment just distracts us constantly. And capitalism and having to consume things constantly, and social media. Like, I do like to scroll on social media, and I know I shouldn't.
We're all guilty of it.
Yeah. And I know it's like, I feel worse after I've done it, even as a psychologist. You know, it happens to us all. But yeah, I think coming back to like the basics, the fundamentals of life are like the things that most fulfill me. And I think as society at the moment, like, we're not getting that right. There's so much pressure on people to balance lots of different roles and responsibilities. It's quite worrying, really.
If you could change one thing about the way society views mental health, what would it be?
That people do things as a form of communication.
What do you mean?
Like, no matter what, I don't know, what could I give as an example? Self-harm, for example.
Mm-hmm.
People self-harm for a reason.
Yeah.
There's always like a function or a communication behind anything. And I wish people were like more curious about that rather than just sticking like a label. Or I think quite often people do it because they're trying to avoid thinking about things that they feel uncomfortable about. I wish people would just be like maybe more willing to try to understand another person's point of view rather than like jump into conclusions, essentially.
Can be quite toxic, I guess, especially like with social media. Everyone's quick to assume and jump on bandwagons and herd mentality and all that sort of stuff.
Yeah.
Very dangerous.
But then as a therapist, sometimes I think we can like just justify everything, like try and explain it in every single way possible. That's something that I struggle with as well.
Trying to explain everything.
Yeah, just, I guess it's more in personal relationships being like, no, this is a boundary, like you've crossed it. Not just being like, oh, well, maybe they did this because...
Yeah, no, definitely guilty of that as well. Can relate. Second to last question. What has studying clinical psychology taught you about yourself? Or how has it changed the way you see yourself?
I think at this point I maybe have a bit more compassion for myself, that I've like managed to get through all of these years of studying, and I think having therapy throughout training has helped with that. So I think I definitely just think about parts of myself that I definitely never used to, which has been hard, but also I think it's healthy to do. I don't know if there's anything else.
It's hard not being able to self-disclose too much either, I guess.
So one example that I'm thinking of is like there's a real focus in training about being anti-racist and thinking about racism. And certainly as a white person growing up, like I just didn't think about that. And just sitting with that guilt of just my world like being sort of blinkered to that, really, I think, and not acknowledging like the privilege I have as a white woman in the world. And that's when, I could be sat with somebody who's very different to me, has had very different experiences. And how could I possibly understand? I can try to understand, but I'll never know exactly what it was like for them. So kind of coming to terms with that. But that is true of anybody as well.
Yeah.
We're never exactly in a person's shoes or have had their experiences.
No. I guess that's the job, isn't it? To do your best to try and understand it and to empathise and it's a tough job.
And also acknowledging, like, talk about on training when there's clients we don't like or clients that disgust us or repulse us, and like what is that about, and being quite honest about like that feeling you have with somebody.
Does that happen to you much?
Well, it's definitely clients that I sort of warm to, or clients that I don't warm to as much, or they've said something and I'm like, maybe disgusted by it or something that they've done. And trying to work out whether that's their stuff or is that mine. Are they actually disgusted with themselves? And that's kind of like the transference. where what they're feeling is just, I'm feeling it.
Mm-hmm.
Can be difficult to unpick. Yeah, and am I warming? You know, it might be that a client reminds me of somebody that I've known in the past. You don't even realise it. And maybe that's why I feel like drawn to them or warm towards them. I think it's helpful to be aware of that because...
Yeah, definitely.
Yeah.
That's what supervision's for.
Yeah,
and
for
all
sure.
that kind of stuff.
Good supervisor makes all the difference.
Yeah, it does. It certainly does. So what's next for you, Liz? So obviously you're coming towards the end of your training. What's next on the horizon for you?
I don't really know, to be honest. At the moment, I'm in liaison psychiatry. I'm in a physical health hospital. But I would like to do sort of more longer term work again. Mm-hmm. So probably through the NHS. But I think in time I would like to do some private work too. Yeah. But I'm also like trying not to put too much pressure on myself to just go on to the next thing, because that is a pattern that also often happens to the best of us. So just to like pause for a while and acknowledge that I've managed to do this. I'm still waiting for my thesis to come back as well, so I'll have that to amend and then hopefully publish it.
Yeah, be cool.
Yeah, but as I said, like more of a work-life balance again would be great.
Good. Last question I always ask, Liz, is there anything from this conversation that you're going to take away? Anything that you've learned or will reflect on afterwards?
I think your question about like self-disclosure and how much I bring of myself to the work, I haven't really thought about it necessarily in that way before. So I imagine as I'm driving home, I'll be mulling that over. Yeah, like I like to think that I am quite transparent and open as I can be with my clients. But yeah, when does that become like unhelpful as well? Especially working in the NHS. I think, most people can acknowledge that the NHS isn't in a good state, but if I say to each of my clients, this is a shit show, you know, or how helpful is that? It's probably not helpful in containing like their anxiety. I can acknowledge obviously when certain things don't go well, but yeah, you kind of need somebody to contain some of that. So
it's a fine line.
I'll think about that, I think.
Yeah, cool. Thank you very much for coming on, Liz, and having a chat. It's been really good. I was going to say, is there a place someone could follow you? Or I know you have a page, but...
I do have a page. It's called Advocate Change.
Yeah.
I'm not very active on it at the moment, but, you know, in the future I might be now I have some more time.
Cool. Cool. Thanks, Liz.
Thank you.
Thanks for listening to Between the Roles with me, Michael Blown. If you've got any thoughts, feedback or questions about today's episode, I'd love to hear from you. You can reach me by email at loquicounselling@outlook.com. That's LOQUI counselling@outlook.com, or through my website, www.loquicounselling.co.uk, or on social media at loquicounselling and hypnotherapy. If you've enjoyed the conversation, please like, subscribe and share it with someone who might relate. Take care of yourselves, and I'll see you next time on Between the Roles.